We're now live.
Do we have anyone waiting to get in, Lauren?
Not at the moment, no.
I can see that Stephen is here. Stephen Gregg's here.
Yeah.
Morning, Mike. Hello, everyone.
Good morning. Oh,
Ian and Tony are just joining now, Mike.
Everybody who was in the waiting room, Mike, has now been admitted to the meeting.
okay. Thank you very much. Good morning. Good morning, everybody, and welcome to anybody who's watching on YouTube. I'm Mike Lodge. I'm the Scrutiny Officer from Calderdale Council, and I provide support to the West Yorkshire Joint Health Scrutiny Committee. I'm starting the meeting because we've changed the agenda order slightly, and that's to go through the election of chair and deputy chair first, so we can get that out of the way, and then the person who's elected chair can take over the meeting. So, members, election of chair of this scrutiny Joint Health Scrutiny Committee until for the municipal year. Have we got any nominations for chair? Councillor Hutchinson.
I'd like to nominate Councillor Greenwood for the chair.
Thank you. Is that seconded by anybody?
Seconded, Mike. Can you hear me?
Yes, thank you, Councillor Rhodes. Are there any other nominations? I can't see any. So all those in favour of Councillor Greenwood being elected chair for this current year?
Agreed.
It looks like it's agreed. Any against? Thank you very much. Election of deputy chair. Are there any nominations for deputy chair?
I'd like to nominate Councillor Smage.
Is that seconded by Councillor Hutchinson, Councillor Baines? Any other nominations for deputy chair? I can't see any. All those in favour of Councillor Smage being elected as deputy chair? That looks like it's carried. Thank you very much. Thank you very much, everybody. I'll hand over to Councillor Greenwood.
Thank you, everybody. I hope you're all okay on this really hot day. I've got my patio doors open, so if you hear any noises outside, it's those. Okay, right, so we'll move on to the agenda then now. So do we have any substitutes or apologies?
We have apologies from Councillor Hargreaves, and Councillor Glentworth is substituting chair.
We also have apologies from Councillor Soloway from North Yorkshire.
I can't get to it. I've had terrible trouble.
Okay, thank you. We've got some new members of this committee as well today, so welcome to the new members. So we'll do some introductions. I'll go in the order that I've got on my screen, if that's okay. So, Councillor Swift. Do you want to introduce yourself, Councillor Swift? And you're on mute. You're on mute.
And I'm not usually as quiet as that. I'm Kevin Swift and I'm from Wakefield.
Hi, welcome. Councillor Hutchinson.
I'm Colin Hutchinson from Calderdale.
Councillor Smage.
Councillor Liz Smage from Kirklees.
Councillor Clark.
I'm Councillor Jim Clark from North Yorkshire.
Councillor Baines.
Councillor Stephen Baines from Calderdale.
And Councillor Abigail.
Abigail Marshall-Cutting from Leeds.
Councillor Latty.
Good morning, Councillor Graham Latty from Leeds.
And Councillor Glentworth.
Councillor Glentworth from Bradford Council.
Councillor Rhodes.
Wakefield. Morning.
Morning, everybody. Thank you. And I'm Councillor Greenwood from Bradford, chair of the Health and Social Care Overrun Scrutiny Committee. Okay, so welcome everybody. So the next on the agenda is, has any members got any declarations of any items on the agenda for today?
Can you split the screen?
No. Okay. Okay, so admissions of the public, and it's not recommended that the public be excluded from this meeting today. Public deputations. I understand we've got Jenny Shepherd here. Is she with us, Jenny?
Yes, hi, I'm here.
Hi, Jenny. Hi,
I can't
welcome.
get the video to work, I'm sorry.
It's all right, don't worry.
So do you want me to go ahead?
Yes, please, yeah.
Okay. So thank you for the opportunity to make this statement, and I'm speaking on behalf of the campaign group Calderdale and Kirklees 999 Call for the NHS. Our main points are that the Health and Care Bill is bad for NHS patients and bad for NHS staff. It would reduce the government's obligations to secure NHS care for us all, and potentially making the government non-compliant with its duty to provide an effective framework for protection of the right to life. And I should say that all these points are referenced in relation to the different bits of the bill in the written document that I sent in yesterday that I hope you've all got. So, and the third point that we want to make is that it seems set to worsen the current NHS frontline staff shortage by threatening national agreements on wages, terms and conditions of employment, deregulating NHS professions, and introducing flexible staff redeployment across NHS organisations based on learning from redeployment of nurses and doctors during the COVID-19 pandemic. We understand from previous JOSC meetings that you on the Scrutiny Committee are not allowed to question government policy and legislation, simply to scrutinise whether local organisations are implementing them in the best interests of the NHS and the public. So when considering the West Yorkshire and Harrogate integrated care system, governance arrangements to be put in place once it's on a statutory basis, and should the bill get through Parliament in its current state, which we do doubt, we ask you to bear the following points in mind. Firstly, the bill is bad for patients. It reduces the government's obligation to secure NHS care for us all. This is indicated in Part 1, 15.1 and Schedule 3, Paragraph 3, new Section 82B. These clauses mean that if Parliament enacts this bill, first, there will no longer be a statutory duty on anybody to arrange provision of secondary, i.e. hospital medical services, only a power for integrated care boards to do so. Second, integrated care boards will apparently only have a, quote, core responsibility for a, quote, group of people in accordance with enrolment rules made by NHS England. And this, to us, evokes the United States definition of a health maintenance organisation which provides, quote, basic and supplemental health services to its members. And the reference in the bill is clause 14, people for whom integrated care boards have responsibility, and new section 14Z31. But our point is the NHS is meant to be a universal service for everyone. These and other measures in the bill raise the question of whether it complies with the government's duty to provide an effective framework for protection of the right to life. And this obligation is imposed by Article 2 of the European Court of Human Rights. We think the consequence could be a systemic or structural dysfunction in hospital services that result in a patient being denied access to life-saving emergency treatment. Second main point, the bill is bad for staff. There's nothing in the bill about NHS frontline staff's national agreements on wages, terms and conditions of employment, but there is plenty about how the postcode lottery payment scheme arranged by NHS England for the new integrated care boards will impose strict spending limits. This new NHS postcode lottery funding system undermines the economic basis for national agreements on wages, terms and conditions of NHS staff. Staff pay at around 65% of NHS spending is the biggest bit of NHS costs. So there will be pressure on integrated care boards to vary it and terms and conditions according to how their area's funding allocation is set by NHS England. The bill would also deregulate NHS professions, and this is in explanatory notes, page 37, paragraph 37, with serious implications for the quality of care, as well as the employment status, pay and terms and conditions of a range of NHS workers. Professor Kailash Chand, an honorary vice president of the British Medical Association, has tweeted, "The core thrust of the new reforms is to deprofessionalise and downskill the practice of medicine in this country so as to make staff more interchangeable, easier to fire, and services more biddable, and above all cheaper." And the Doctors' Trade Union, the British Medical Association, has already rejected the bill. Thank you, that's it.
Thank you very much for that, Jenny. Thank you so much. First of all, before we move on, I'd just like to apologise to Councillor Ramsey. She's not got councillor in front of her name, unfortunately, so I've missed you out. So welcome, Councillor Ramsey. You're one of the new members to the committee. So do you want to introduce yourself?
Councillor Jackie Ramsey, and I'm from Kirklees. Thank you.
Okay, thank you. Okay, so minutes. I think that's handed over to you, Mike.
Thank you, Chair. We've revised the minutes from previous meetings because members asked for a bit more detail to be included. So that's why there are 3 sets of minutes for you to approve. So I hope they're okay for you now. So that's why we've got 3 sets of minutes. Thank you. You're on mute, Councillor Green.
Sorry. And in the minutes as well, you asked me as chair to write to Rob Webster, Chief Executive of West Yorkshire and Harrogate ICS, thanking all the NHS staff for all the hard work and commitment that they've performed throughout this pandemic. So we've received a letter from him now thanking us for that letter. So it'd be, I think, nice if members would circulate it around to their local CCGs and NHS. Okay. All right. Thank you for that. Okay. So business items now, the health and care bill governance implications. And we've got Stephen Gregg with us today to present that report. Over here, Stephen.
So yeah, I'm here. Yes, Councillor Greenwood. I think Ian Holmes is just going to say a few words at the start of the item in terms of the context for the item there. Thank you.
That's fine. Can you both introduce yourselves as well before you speak? Thank you.
Yeah.
Go on, Steve.
I'm Stephen Gregg. I'm the governance lead for the West Yorkshire and Harrogate Health and Care Partnership.
And hi everyone, my name's Ian Holmes. I'm the director for West Yorkshire and Harrogate Health and Care Partnership. So we've shared a paper with you, but we've prepared a few slides as well, if that's okay, if you don't mind me sharing my screen. I've got a few slides to set the context for this item, and then Stephen will take you through some more of the detail, which is covered in the paper around the specific governance issues and considerations we're looking at as part of this. And I've been told that host has disabled participant screen sharing. So I don't, Lauren, I don't know whether we can.
Bear with me 2 seconds, Ian, and I'll enable
Thanks very much. I'm not hugely familiar with Zoom at the best of times, so apologies for that. We're used to Teams in the NHS, unfortunately.
You're good. You should be good to go, Ian.
Great stuff. Thank you very much. Can I just check? Can you all see that? Yeah. Great stuff. So it's probably worth starting with a little bit of our context as an ICS moving into these next set of arrangements. So we've been working this way for 5 years across West Yorkshire and Harrogate. We've got a partnership that's built on strong place-based arrangements. We've got 5 strong, well-defined places, mature provider collaboratives for acute services and mental health services, and fairly inclusive, transparent system leadership arrangements, including a partnership board, which has been meeting in public for over 2 years now. We've got a partnership memorandum of understanding that we've discussed with you previously, which describes how we want to work as a partnership. And we think all of these things together provide a pretty strong platform for the future design work. And we see the move towards a statutory set of arrangements from April next year as the next evolution of a journey we've been on for some time, rather than a significant change in direction. We did a lot of work last year that you were involved in around our 5-year plan, which set out what was collectively important to us and remains collectively important to us. And what we've seen during the pandemic response is that the collaboration and relationships that we've been able to build across NHS partners and across NHS and wider partners have been strengthened. And again, that will help in terms of the direction of travel around integrated care systems. We're in a sort of a slightly unique situation in that the changes proposed by NHS England and the Health and Care Bill reflect that legislation is actually catching up with working practice. We believe it matches what we do in a number of respects. We believe we can make the bill work for us. The other helpful thing is that the bill continues to signal a good degree of permissiveness. It's not overly prescriptive about the arrangements that ICSs must have in place. And this is important because if you look up and down the country, integrated care systems all look and operate in a slightly different way. It's really important to remember as well is that legislation doesn't define the tasks, it doesn't improve outcomes itself, it doesn't define our values or our behaviours. That's something that comes from the partnership. What it does is it sets a framework for how we work. In terms of the latest position, where we are in terms of the national process, so there was a document published in June called the Future Design Framework from NHS England, which set out further information and guidance on how they see integrated care systems working, and we've reflected that in our governance work that Steve will come on to. There's been the first and second reading of the bill now, which happened in early July, which is good and helpful in terms of getting towards that milestone for implementation of April 2022. We're expecting that second reading of the bill will trigger the recruitment of the chair of the ICS board. So there will be a chair of the statutory integrated care board, and we expect that process to happen imminently. The recruitment of the substantive chief exec will follow shortly, hopefully in the next month or so. And within all of that, we're working towards implementation of these new arrangements for April 2022. So it's a tight timescale, tight set of deadlines, but that's the high level sort of milestone that we're working towards. I guess when you talk about legislation and structures and governance, it's sometimes easy to forget what we're here for and what's important to us. And I've just included this slide as a bit of a reminder. Apologies, the words on this might be slightly small, but this is a slide that we shared with you when we were developing our 5-year strategy last year, and it describes how we will work together in neighbourhoods and communities across places and across the ICS to join up services, and so that we can put the citizen at the centre of everything that we do. That framework and that way of working is absolutely as important to us now as it was when we wrote the plan last year. And all of these changes are for us, are how we work together to ensure that we are joining up services at those 3 geographic levels. But what we know is that the context that we're working in is significantly more challenging than it was last year. Just a couple of slides to illustrate that. I'm conscious we've got an item on the agenda around system pressure, so I'll not get into this too much, but this is an example of how COVID has widened inequalities. So this is risk of death involving COVID-19 for disabled groups and non-disabled groups. And what this shows you is that for more disabled groups, these 2 charts at the bottom, you're 3 times greater risk of dying if you're a male, and almost 3.5 times greater risk of dying if you're a female. So we've got ambitions around narrowing health inequalities, and what we've seen is the pandemic has acted in the opposite direction of that and has widened the inequalities that we seek to narrow. We've also seen significant pressure on services. And what this slightly busy chart shows is performance against the national 18-week standard for elective care and 6-week target for diagnostics. What it shows is that probably since about 2012, performance against those standards have been gradually deteriorating. But what we've seen since the start of the pandemic is a significant deterioration in performance against those standards, up to a point where over 50% of elective treatment and 50% of diagnostics were not being treated within those 6 weeks and 18 weeks targets. And again, we've got ambitions around earlier diagnosis for people with cancer, because that's the best way to save their life. And again, those ambitions are much more challenging in the current context that we're working in. So that's just a reminder of ensuring that we don't let these changes become a distraction to the key business that we need to focus on over the coming years. So the Health and Care Bill implications, and I think most of this will be familiar to you now. So what the bill says is that ICSs will be established in 2 ways. So there'll be an integrated care partnership, which will operate as a joint committee. We think this will be a broad and inclusive partnership, which will be responsible for setting the strategy for West Yorkshire and Harrogate in a way that addresses wider health, public health and the social care needs of the system. So it will not be just an NHS plan, it will be a health and care plan. This will operate as a joint committee, and we see it functioning in a similar way to that of our partnership board. The details regarding the specific functions and membership of that group are left to local discretion, and that's some of the detail that we're working through that Stephen will be able to update on. And then there will be an integrated care board, which will be responsible for developing the plan to deliver that overall strategy that the partnership sets. It will take on the functions of CCGs and be directly accountable for NHS spend and performance within the system. It will have a chair which is independent of local partners and a full-time chief executive. So that's the sort of the 2 statutory ways in which integrated care systems will be established. But as part of this, we're really clear that place level working will continue to be critical in the future, and those place-based arrangements that have emerged and evolved across West Yorkshire, those close partnerships between local authorities, NHS, voluntary community sector organisations, Healthwatch and other partners will continue to be an important part of the way of working. As an ICS, we expect the majority of our functions to be delegated to place level. And again, Stephen will talk a little bit about our thinking around that. And really importantly, health and wellbeing boards will continue to have a really important responsibility at place level in setting that strategic direction at place level in a similar way to expect integrated care partnership at West Yorkshire level to set that strategic direction of travel. And as we've said previously, there's a really strong emphasis on collaboration throughout the bill, and a move away from competition, which we think will be helpful in allowing statutory partners to integrate services around people. So I'll pause there, and Stephen will take you through more of the specifics around the governance work. Do you want me to drive the slides, Steve? Is that the easiest thing to do?
Yeah, if you can, please, Ian, that'd be good. Yeah. Okay, well, thanks, Ian. You've obviously seen the detailed paper on the governance arrangements. I'm not going to go through that in detail, but I thought it might be worth just headlining some of the key messages from that. And just to emphasise the context that Ian set, the principles we've set ourselves in designing our governance arrangements is they need to help us to deliver those big ambitions that we've set ourselves as a partnership around tackling health inequalities, around improving the health and wellbeing of our local communities. And the way we do that is through our principles of subsidiarity. So the main test of our new governance arrangements will be whether they allow authority, resources, funding to flow effectively to place, to our local places who are responsible and will continue to be responsible for delivering the vast majority of health and care services. So that is, if you like, got to be the key test of our governance arrangements and the key principle we're following. But that obviously also has to be supported by some of the wider principles of good governance, not least of which we want to make sure that our arrangements from April next year are transparent and accountable. So we've already got a partnership board that meets in public. We want to carry on that approach. And we think obviously there's a really important ongoing role for overview and scrutiny in making sure that we are transparent, we're accountable to our local populations for the work that we do. But alongside that, as Ian said, we think that for the last 4 or 5 years, we've worked, I think, effectively, but within a context of legislation that really hampers effective collaborative decision-making, where we've had to take decisions in 3 or 4 different places because of different statutory responsibilities. So we think that there's a real opportunity here to streamline that decision-making, to make decisions once collaboratively, rather than having to then take those decisions back out to a series of individual organisations. We think we do start from a strong foundation. It's all very well having robust governance, but unless you've got unless you've got a set of partners that actually want to work together effectively, want to collaborate, trust each other, and have built and invested in those relationships and that culture, then it doesn't matter how robust your governance is, you're not going to get to the outcomes that you want. So we think we are building on really strong values and relationships, and we think we've got some good components across our system in relation to clinical, professional leadership, strong involvement of local authorities. We've got some good arrangements around patient and public involvement. And all these are set out in the Memorandum of Understanding, which Ian referred to earlier. And again, part of our overall approach is that we put a lot of effort, collaborative working with partners to develop that Memorandum of Understanding. And we want to keep what works. A lot of that has worked for us well over the last 4 or 5 years. And we want to adapt that rather than starting completely afresh. We want to adapt that to meet our new ambitions, obviously the legislation and the detailed guidance as it comes out. And part of that is obviously building on strong place arrangements. For example, the scrutiny arrangements, which are well established at both place and system level. In order to get next April to a set of governance arrangements which everyone has faith in and everyone supports, we're taking a co-production approach. We've got a governance working group with representation from across our system, health, local authorities, voluntary community sector. We've got representation from Scrutiny through Mike Lodge. We've got representation from Health Watch. So we want to make sure we develop these governance arrangements together so that we align what's happening in place with our providers and system governance, and link it to the work we're doing to support places to develop their own arrangements. So we very much think it's the process we go through as opposed to the end arrangements on the documents that are really important. Next slide, please, Ian. So I've just highlighted here, I mean, in the paper, it goes into a bit more detail in some of these, but just thought it'd be worth highlighting what we see as the key governance issues that we need to get right. And based on what I said earlier around subsidiarity, the key thing to get right is the scope of the delegation to place, how that works in practice, and our places are looking at different approaches to joint committees with partners, committees of the integrated care system, different mechanisms to make sure that we get that effective flow so that the decisions are made, continue to be made in place, and decisions about resources and about services continue to be made in place. So there's a whole scheme of work we're doing around making sure that we're true to our principles of subsidiarity and those delegation arrangements are clear. But alongside that, that we've got clear accountability and assurance mechanisms built in at every stage of the system, whether that's at neighbourhood, place, or system level. I've mentioned transparency and probity as being a key part of our future arrangements. We want to make sure we've got citizen voice that reflects our communities at every stage and in every part of our system. That's important to us. And that we think there's an opportunity to strengthen that with the new arrangements. Reference the importance of independent challenge, whether that's through non-executive or lay representation on key decision-making boards, or whether it's around the scrutiny process, audit and assurance. We need to make sure we've got all those components in place. And in particular, we need to make sure that we manage conflicts of interest effectively. Obviously, with greater collaborative working, with greater working with providers and with provider collaboratives, that raises issues of conflicts of interest. We can't avoid those issues, but we need to make sure we manage them effectively. We want to make sure absolutely that our partnership at all levels is inclusive, both of statutory and non-statutory partners. And we need to strike the right balance there between inclusivity, getting the right people, getting the right voices around the table, and making sure that our decision making is effective and streamlined. And lastly, but by no means least, and I think it often is overlooked when people talk about governance, governance definitely isn't just about process and mechanism. It's about getting in place the decision-making processes that support the values and behaviours and the way we want to behave with each other as partners. So we're absolutely committed to using our governance arrangements to take forward collaboration, and we think there's an opportunity to get greater diversity and equality in our leadership and our decision making. Again, we're not just thinking that it's going to be business as usual from April of next year. We think there's some real opportunities to actually take forward some of our ambitions in the way that our governance works. Next slide, please, Ian. So just in terms of the detailed work we're doing, we've done some initial work to look at what our existing MOU says about how we operate and map that against what the bill now says, and in the future weeks, what individual pieces of guidance from NHS England say as well, so that we're building on that strong foundation and getting something by April of next year that people buy into and support. We're doing work with our places about what good governance looks like in each of our places, the aim being to get a set of standards around citizen involvement, around independent challenge, around managing conflicts of interest, so that we know that whilst different places will do the detailed governance, and their committee structure may be different in each place depending on local place needs, we think that needs to be in the context of some clear standards around what governance good governance looks like. So that's a piece of work that we're on with at the moment. We very much want to test our emerging thinking through workshops where we take some case studies around really kind of thorny issues, whether that's hospital reconfiguration, whether it's the wider issue of how we address health inequalities, whether it's an issue around serious quality problems within our system. We want to test our arrangements against some of those kind of knotty problems. We think that regular progress reporting at all levels is important. We want to take everyone with us as we develop our arrangements. That needs to be iterative. The bill was only just produced, had its second reading last week. So we know we need to develop those arrangements as the bill carries on its legislative process and as we move from principles to firm proposals. But we want to take the first draft of what our governance arrangements will look like to our partnership board meeting in public in September. And throughout that, we'll be continuing to do further updates with health and wellbeing boards, CCG governing bodies, overview and scrutiny, so that what we don't want to do is go into a darkened room and come up with a set of governance arrangements next April that people aren't bought into. So transparency and openness, I think, needs to be a key part of our approach. And all of this at the same time, Ian mentioned that the permissiveness in the bill, that to us is important. We think we've got a system which fundamentally is sound, and we want to make sure the legislation supports the development of that rather than holds us back. Just close with the overall timelines, which I think Ian was just going to say a few words about.
Yeah, thanks, Steve. So this is just a kind of an indicative timeline that came from the National Design Framework, which is around sort of confirming designate appointments for the Chair and Chief Exec by the end of September. We'll have proposals by then for how this is going to work, in the sense that the ICS will be operating in shadow form for them. So we'll have kind of mirrors of the new arrangements in place. And then you can see there's further deadlines in December around the designate appointments of the ICS body and leadership roles, and the place-based leadership arrangements and non-executive roles too. By the end of March, we expect all of those appointments to be in place, and that we've carried out the due diligence around transfer of staff and property, etc., to the new organisation, with a view then to having the new arrangements in place fully from April the 1st. So I'm going to stop sharing my screen now and can open that up to any conversation and questions.
Okay, thank you for that. We've got a few hands up here. Councillor Hutchinson.
Thank you, Chair. The actual bill is quite, you may say it's permissive, but you could say that it's quite vague in a lot of areas, particularly around management of conflicts of interest, because it's allowed at both integrated care board and at integrated partnership level for bodies that are profit making to sit on these boards and also to be awarded contracts through them, which could maybe of very high value, very long duration, without abiding by the Public Contracts Regulations 2015, which have been in place so far. The governance arrangements are obviously extremely important as to how to manage these conflicts of interest. And so much seems to stem from the constitution that is of the integrated care system. My understanding is that this is to be drawn up by the existing clinical commissioning groups primarily, and that a draft is going to be presented to the partnership board in September. What scope is there for Scrutiny to have an input into that, the drafting of that constitution, preferably before it's submitted to the partnership board, although I know that it is a process that's going to be going on for a number of months after that.
Do you want me to kind of pick up that the high level point, and then Stephen, I don't know if you want to pick up some of the detail around conflicts and contract awards. So I think the short answer to your final question is yes, we will. We're hoping to get a first draft of this to the partnership board in September, and as Stephen was describing, a process of engagement and iteration of that between September and in April next year, so that all partners have got to have the opportunity to play into that, so that we can understand their issues and concerns, and so we can kind of co-produce it together. As part of that, I'd absolutely see a role for Scrutiny, and it would be really helpful to have a conversation about that at the right point, whether that's before the partnership board in September or after. Councillor Hutchinson, I can work with Mike around the specific timescales around that, but the principle would be that we'd want to have a conversation around that emerging constitution with this forum. Steve, I don't know if you want to say anything about the detailed points around conflicts and contract award.
Yeah, I mean, Councillor's absolutely right to identify that, you know, management of conflicts of interest will be a key part of the arrangements from April of next year. CCGs have obviously operated to specific NHS England guidance around that, and we're anticipating that there will be a new set of statutory guidance which applies to integrated care boards to replace that. But having the guidance is one thing, getting that embedded into your processes and systems is another thing. I mean, I suppose that there's a broader point that we do not envisage. We envisage that the vast majority of health and care services will, as now, continue to be provided by NHS local authority providers. We're not envisaging that there will be independent sector providers on the board of the ICB, for example. I know some systems have gone down a different line. So yeah, that's a kind of, you know, the overall point. But obviously within the way that we operate our governance, both at system and place level, we will need to apply whatever standards NHS England set out in terms of that management. We will need to make sure we've got the arrangements in place in relation to independent scrutiny, non-executive and lay members, to make sure that we do manage conflicts. I think we know we can't avoid them. Providers are, you know, a key part of our system and need to be so, but we do need to have in place those arrangements. And I think once we've seen the national guidance, we'll adapt it, make sure that our arrangements in West Yorkshire and Harrogate are as strong as we can get them.
Chair, can I just ask, although, you know, these arrangements are going to need to stand the test of time, then, you know, people may be setting these up with the best will in the world and with very, you know, clear in their own minds as to how they operate now, but they need to be able to continue to operate for the coming years. So are you suggesting that for-profit providers would be excluded from sitting on the integrated care boards as a matter of the constitution of the ICB?
No, I'm not saying it would necessarily be part of the constitution. I'm saying we don't envisage at present that there would be such a role. And there will be further. We've seen the bill. We will see a range of further guidance about the composition of our ICB's boards and place arrangements. And we'll need to make sure that whatever we put in place in relation to our constitution reflects that. But it's certainly not our intention at present that there would be members of ICB boards.
Okay. Councillor Smage.
Thank you. I'm afraid my question is in 6 parts, but I'll be quick as to the 6 parts. So do you have a pen ready? Right, okay. So can you just confirm, please, talking about the Constitution in September and then going out to consultation on it, can you just confirm, please, that it isn't just health bodies that are discussing the Constitution before September, that you also have local authority input into that first drafting, please? I wouldn't want it just to be the CCGs that are doing it on their own. I think it is a health and care bill, and therefore it needs different partners at the table on that. In respect of your governance, there is in the bill several times it says duty to have regard to the wider effect of decisions. And I'd like to know how you're building that into the discussions on your governance, please, because that's just not coming through at the minute. Health inequalities, well, absolutely. And I hope on this gap analysis that you're doing of your MOU, that you will take on board Scrutiny's comments previously on the MOU, that health inequalities should be front and centre of that MOU. And not as a little bit of an afterthought as it was before, as it seemed to be before. How are you getting new voices into your governance structure? And also the bill talks about your 5-year plan, and you've talked a lot about your 5-year plan. It talks about having your 5-year plan updated by each financial year. And I'm wondering if you're going to have a refresh of that while you're in shadow form this year, so you can see how that refresh runs in shadow form before you get to next April, and how you're going to do that refresh. And then can you just expand on the place governance structure, range of governance models that you talked about in your paper? Thank you.
Steve, do you want to have a crack at those, and I'll try and pick up anything that you don't cover?
Yeah, absolutely. Yeah, the first point around the Constitution. Yeah, you're right. In the bill, it places the responsibility on CCGs to consult and prepare the Constitution. And although technically that's in the bill, we've taken the approach right from the start, and we'll continue that. We are co-producing it with across a full range of partners. So the governance working group is the kind of officer level group that does all that work. As I say, it's got CCG representation, it's got local authorities, it's got Health Watch, it's got our racial equality network, it's got Scrutiny represented, it's got providers. So yeah, and then that reports into, again, within the partnership groups that are multi-sector. We've got local authority leaders, we've got a chairs and leaders reference group, we've got a future design group, which has got the full range of partners. And ultimately, it will go to the partnership board, which is obviously the most inclusive part of our partnership. So absolutely our intention, although the CCGs have the duty, formal duty set out in the bill, we see it as something which absolutely has to be co-produced right across the partnership. In terms of that duty around wider effect of our decisions on other areas, we see one of the best ways we can address that is by making sure that our partnership is as inclusive as possible, so that we've got a wide range of voices around the table at neighbourhood, place and system level. We can't always have everybody around the table, but we're absolutely wedded to the fact that we need to have an inclusive partnership. It just isn't strongly just focused on health or social care, but it's looking at the wider determinants from sustainability to climate change, so that we're not just taking decisions in a health and social care bubble, if you like. In relation to the MOU and health inequalities, there is an opportunity. Health inequalities, it's front and centre within our within our 10 big ambitions. That those are the things that drive us, and our governance arrangements need to support that. So absolutely right that, and our constitution will set that out very clearly. That our arrangements are around supporting that, that overriding ambition of reducing health inequalities. You've talked about getting new voices into our partnership arrangements. Yeah, we're working through that as now. We really welcome views on how we can best do that. It is a challenge that we know we've got. We want to make the partnership inclusive. We want to make it more, the public voice more representative of our communities. We also need to balance that against effective decision making. So we're welcoming and we're going out and seeking views on how we can best do that going forward. In relation to the refresh of the 5-year plan, and that's probably something that you could pick up.
Yeah, should I come in on that one? I think it's a really good question, and it's something that I've started to discuss with a few people in the system. I guess the balance is there's a huge amount of work and a huge amount of pressure going on now. The COVID response, the vaccine program, the other pressures in the system which are significant, the work that we're doing on future design, and I think the sort of the judgment we'll need to take is whether now is the right time to refresh the strategy in that context when everybody's kind of time and headspace is rightly focused on those issues. So something we're considering, Councillor Smage. It's just balancing the sort of those kind of competing requirements, I think.
Yeah, and the final point around place governance arrangements. I mean, the Future Design Framework sets out 5 broad approaches: consultative, collaborative committees, formal joint committees between a range of statutory organisations, including NHS and local authorities, a committee of the ICB, which again would have a wide representation, but would not technically be a joint committee, individual delegation to officers at place level, and provider-led collaborative approaches. We are going through the process now of looking at, and places are, of what arrangements works best for them. What is it, a joint committee? Is it a subcommittee? How do you mix that up with individual delegation? The same with I guess, questions at an individual organisation level. You've got to get that mix right between effective and quick decision making and collaboration. But absolutely, that's right at the centre of the work we're doing, and it will be reflected in what we bring back to the partnership board and how we iterate that over the next 6 or so months.
Okay, can I just quickly, this is obviously a very multi-layered governance structure that you're going to put in place. And I do think, as Councillor Hutchinson suggested, that it would be good if we could find a way for Scrutiny to be involved at a very early stage. We've got Mike that's looking at it with you as well, that Scrutiny could be involved at a very early stage, and that we have discussions from this committee as to how we can do that to scrutinise going forward this, because it is going to be quite complex governance arrangements by the sound of it. And on your 5-year plan, I was asking because the bill says you've got to involve all the health and wellbeing boards in those discussions. And I was concerned that all of this could drown out the need to refresh where you're going in light of what has happened over the past year and a bit, so that 5-year plan is definitely fit for purpose for moving forward. Thank you.
Absolutely, and we would absolutely involve health and wellbeing boards in that process as we have done in the past.
Thank you, and well done for answering all those questions. Councillor Swift.
Yeah, thank you. Right, my question overlaps to some degree with the questions and answers to Councillor Smage's questions just now. But it was really to say there's considerable emphasis in the paper that was circulated ahead of the meeting, Stephen Gregg's paper, on the fact that scrutiny would continue to occur to a very, very substantial degree at what is termed place level, and that they would expect existing providers to continue with their existing scrutiny arrangements at that level. Okay, I think one can reasonably envisage how that might work satisfactorily in terms of providers. Now, but it becomes more complex when it's at the commissioner level, i.e. the integrated care partnership, because to have effective scrutiny at place level, there needs to be somebody accountable at place level that we're actually talking to on the commissioner side. Otherwise, there's a dire risk that either things become very, very nebulous, or alternatively, that we're talking to people, we're talking to officers of a West Yorkshire organisation, that's just that, to be honest, that bit too remote to respond, and that would, in practice, in relation to local scrutiny, we'd have somebody coming along to explain things to us, and that communication could become very, very one way. As I say, what would you envisage there would be at the so-called place level on your side of the fence that had got some degree of accountability, some degree of autonomy?
So yeah, so I think it's a really good question. I mean, our view is that the scrutiny function at place level is really important, because that's going to be the main mechanism of delegation function. So there's going to be significant functions delegated to place level. Your point around a point of NHS accountability in place is really important, and we agree with that. We're looking to identify sort of that person, that point of NHS accountability in place, who will work either through the sort of the joint committee arrangements or the subcommittee arrangements that Steve's been describing, so that there is that sort of, you know, direct point of accountability. So that will be there, Councillor Swift. Steve, I don't know if there's anything you want to add to that.
No, I don't think so. Again, we're in the places are in the process of working through, both in terms of committee structures and individual delegation, what that will look like. Absolutely, that's what we will have. We will have clear accountability at individual level, and in terms of collaborative level, come April, that's got to be right at the centre of our arrangement. So, yeah, it's a very good question.
Sorry, thank you, Chair.
Okay, thank you. Councillor Latty.
Thank you, Madam Chairman. I think that what I'm going to ask, because place is the thing that was bothering me as well, and I do think we seem to have said an awful lot about it, but more in terms of the relationship of places. There are places that will be big, places that will be small. There must be surely checks and balances in place, or there need to be, to ensure that the big voices don't drown out the little voices. In other words, that there is, for example, always the feeling that Leeds, being a big place, leads the field, swamps the field, and other people, whilst they don't come second, but they sometimes feel that they do. This will have no place in a place-based approach. So what are we doing to make sure that place is an identity, not a ranking?
So I think you're quite right. I think we've got 5 very different places across West Yorkshire, and what we're trying to do in sort of the work that Stephen's described is set a kind of a minimum expectations for place, without saying actually this is exactly what those place arrangements will look like, because they are quite different. So that's the approach. But again, as Stephen's described, we want places to sort of develop arrangements that work for them within that framework. In terms of the sort of the Leeds drowning out the West York, kind of the other smaller, if you like, partners across West Yorkshire. I mean, we've worked really hard to build something that feels like an equal partnership based on distributed leadership, with leaders from across all part of the partnership. I haven't felt genuinely today that it's felt Leeds dominated or Leeds centric. We've got really good representation from partners right across the system. You know, if you look at the chair of the partnership board is a councillor from Calderdale. You know, Rob's previous organisation, Rob Webster, was Wakefield. And I think we've done quite a good job of doing that. And actually, I don't get the sense that Leeds are interested in having a sort of a takeover of the West Yorkshire arrangements either. So it kind of works. I think we will need to guard against that, particularly in the way that we define the roles for the integrated care board and make sure that's kind of representative of place and of sector. So I think it's a good point, but I don't think that's the way it's felt, and I would hope that's not the way it's going to go in future.
Thank you for that. No way was I trying to indicate that Leeds should have a bigger place, even though I represent Leeds. No, it was just merely an example that, as I say, that when we look at place does vary a great deal and can carry more weight in some places. But anyway, at least we're very much aware of it from the sound of it, so thank you.
Okay, thank you for that. Councillor Rhodes.
Thank you, Chair. Can you hear me okay?
You've muted yourself, Councillor Rhodes. We heard you before.
There we go.
That's
Can
it.
you hear me now?
Yes,
okay.
yes.
Right. I'm just going to make some comments first, if I may, Chair. And I'm not going to go in depth because I fully support the comments that Councillor Hutchins had made regarding procurement and the ability for what's envisaged of these boards and independent people to be sat there who themselves may be involved in contracts that could be allocated. We've seen too much of that already. And I think it's important that we have transparency that has been mentioned by Stephen. And of course, the other issues about the paper going in September, that's important because we're not just here to scrutinise, we're here to overview as well. And it would be no good afterwards saying, well, this should have been done with that, or we have a comment on this, that and the other. We need overview at every stage. And I will go back and refer back to the comments that Liz has made and you've made yourselves in terms of the memorandum and indeed how it came out in draft form and it was then signed off by chief executives of councils. At that particular time, as Councillor Smage, Liz has indicated, we did make comments. And I can't see that when I refer back to my memory of it in terms, I think, that they made much difference. And now I'm going to go on to the questions in terms of that process that's been in place 5 years, which has been heavily promoted as the panacea for the future. We had the development back then, which was the board, and indeed the board met 4 times a year. And we had SOGA underneath, who were the operational arm. And a lot has been spoken about place, and we hear it a lot again today, place, place, place. I would love to know, going forward and using that example going forward for the future, of what the achievements have been made through the place plans and through the health and wellbeing boards. Because I think they were all greatly put to the test in wanting in areas through various reasons, whether it was the staffing levels and through the SOGA. We had a working group set up there looking at future workforce planning for staff. That hasn't been mentioned at all. That's got to come forward as well. And we never had any update in terms of the work of the development of SOGA and how that fitted into the main board. And being as that's the panacea for the future, I think it would be good to know what it actually achieved, other than we're hearing again today of multi-layers, as Councillor Smage has mentioned, multi-layers of committees out there again. The accountability and the responsibility is being mentioned, and that's got to be a prime source of any constitution in its transparency. Those are just general comments, but I'm going to come back on some of the issues that are mentioned, if I may, today. Could you tell me, whether it's Ian or Stephen, you mentioned the citizen's voice in transparency and openness. And then you went on to say that, in fact, seeking views, going out there, seeking views from various bodies. Can you tell us what you mean by the citizen's voice? How's that going to be managed? And I know that Liz has mentioned earlier on about the consultation going to be public, because the last one certainly wasn't aimed at the public, and the public weren't as aware as we would like them to be. So I think that that's very important. The Constitution has been mentioned as well, and I'm very concerned about the Constitution being built in at this stage to make sure that propriety, openness and transparency is there for everybody. So who are the voices that you're going out to? Where are they? How accountable are the voices in terms of the public? Are you going to have any voice-led open events for the public? They don't seem to have happened at all in any of the 5 years, and I mean public. They don't seem to have happened in any of the 5 years at all in terms of the situation that we've had. And you're on about governance groups again and involving local authorities. Well, I think that's down to us as representatives of our own authorities to find out how accountable these local groups are going to be and how they're going to fit into your idea of consultation. And they're going to be as inclusive as possible. Can you tell me what you mean by as inclusive as possible with partners? I know there's a lot of work going on, but I think we need to be able to see what the meaning behind the words are. They're very buzzwords. They've been around a long time, but the buzz has got to produce outcomes. And I would love to have some answers to these. And lastly, as Councillor Smage and Liz and I, we've been around a long time, Councillor Clark, etc. And over the years, and certainly at our meetings when we went to the initial setup of the ICS and the Memorandum of Understanding, etc., Councillor Smage quite rightly and I, we at those meetings, as long with others, put on the agenda the importance of health inequalities and how that was going to be looked after. We've had exceptional circumstances, I know, this last 18 months. But we're putting this amongst, I believe Stephen said, the top 10. The exceptional and awful circumstances that our communities have been through has proven that in the 3 years before that, nothing changed. Nothing changed of the health inequalities across our district. So what have you been doing to address the health inequalities, looking to working with the local health and wellbeing boards and other bodies? And I would like to say as well, and remind everybody, that the involvement of Health Watch is an involvement of those bodies and others as a body themselves scrutinising on behalf of the public, and their view is on behalf of the public. So I'm very concerned that we're having all the buzzwords, but I would like some answers to the questions that I've asked in terms of what has happened in the 3 years before the exceptional circumstances that everybody was in. And if we're putting health inequalities in the top 10, what happened in the 3 years previously across our patches of the work that was done by SOGA as a developing group and arm? Is there some reference to any work that has been done that would enable us to have confidence in going forward that we're actually doing better in the future than we did in the past?
Stephen, I don't know if you want to pick up the first bit about citizen engagement and voice in the works. We discussed that a couple of weeks ago in the governance group, didn't we? And then James Thomas, Dr. Thomas has arrived. And I don't know if you spotted him. I don't know whether there's anything you want to add on the inequalities work that we're doing through the Improving Population Health Board after Steve. Is that okay?
Yeah, in relation to citizen voice, yeah, we're absolutely, as Ian said, the discussion at our governance working group last week was very much focused on, okay, we don't want to be coming up with a set of proposals and then that's a fait accompli. So what we're doing, we're working with our places to develop a set of arrangements which we think work. We absolutely think we need to get the public's view on that. We can use proxies for getting the public view. Health Watch, for example, sit around the table for our governance working group. But we absolutely know that we need to, we want to do, we talked about running some focus groups to get some citizen voice on the arrangements as they develop. Perhaps before you go on to the wider health inequalities point, the point around the Constitution, I think the one thing I can guarantee is the version that goes to the Partnership Board in September will be nothing like the final version. So it's very much an iterative process. You know, that will be a first step at a structure of what a constitution will look like. So we're absolutely up for comments, engagement with a range of partners, with overview and scrutiny every step of the way, because we do want it to be something that has been properly scrutinised over a period of months. So yeah, September is very much the first stab at it.
Do you want to come in, James?
Yeah, hi, I'm James Thomas. I'm a GP, but I also am the joint senior responsible officer for the Improving Population Health Programme at West Yorkshire and Harrogate, along with Robin Tuddenman, who's the chief exec at Calderdale local authority there. I suppose in terms of response to the health inequalities, I think in terms of prior to, we've all seen what's happened with COVID. We've all seen how it's highlighted the issues, which is what you mentioned there. You mentioned about it being one of our top 10. I would actually say I think it's involved in actually most, if not all, of our top 10. It's the golden thread. It's our biggest, one of our aims is about reducing the health inequalities, whether it's about climate control, whether it's with mental health and learning difficulties there, whether it's with our cancer and prevention there. It runs through all our ambitions there, rather than it being one of the 10 there. But I think it runs through them all there. I think, and I'm happy to share a report we did kind of mid last year in terms of what the Improving Population Health Programme has done over the last kind of 12 months prior to, during COVID, the first part of COVID, and also prior to COVID, in terms of some of the outcomes we've achieved working with our places. And it's really important to stress this, because this is not something that we just do across West Yorkshire as an ICS, as a health and care partnership. This is working with our places, because that's where this happens, and really important how we get that across. So we have done multiple things, and an example would be some of the funding we've worked with, bringing together voluntary sector and health together to look at specifically how we tackle some of the issues that have been highlighted through COVID with health inequalities. I think we're also looking at beginning to look at housing as well there. And then one of the big things we did as a collective across West Yorkshire earlier this year, during February of this year, was to bring together and launch the West Yorkshire and Harrogate Health Inequalities Academy, which is the first of its kind across England there, and it's bringing together the resources that we're seeing from each place to share some of the good practice and understanding across many aspects of the health inequalities within our places, so that we don't make the same mistakes that we may make we may have made, but we also capitalize on some of the successes that have happened, so that we can share that across our places there. Also, it was the launch of it as well. So since then, we've further developed other areas in terms of making sure we have a concrete understanding across our organisations of what actually health inequalities is. So we're all starting from the same basis there. Also looking at kind of fellowships across our places, especially involving our voluntary sector, to try and help how we kind of tackle some of the inequalities there as well. I'm not really giving a great summary, but I will absolutely share with the committee the presentation we have describing what we have done in the Improving Population Health Programme, and specifically around health inequalities there. And I think this was prior to COVID as well. So whilst I think I pick up on the fact that you said, yes, it's highlighted through COVID, and what have we done beforehand? That I think we brought together as a West Yorkshire and Harrogate Health and Care Partnership, the right people to start to look at this across our system there, and we started doing some of this work that I've highlighted prior to actually COVID coming along there. So. As I suppose what I'd like to say is it is front and centre. It's throughout our ambitions. And I'm very happy to share some of the work that we've already done. But it's going forward. It's paramount. It's one of the things that we need to be looking at as we look at everything in what we're doing. And question we should be asking ourselves is when we are making decisions, is how does this affect the inequalities within our populations and our communities? And a lot of the work that's happening most of the work that's happening is happening in our communities and our places with our communities and voluntary sector and our populations across West Yorkshire and Harrogate. I'll stop there, but I'll happily answer further questions.
Thank you, Chair. May I come back? Thank you. Thank you, James. Right, okay. You will recall I wasn't the one that said it was part of the top 10. You may not have been.
Sorry.
Yeah.
Apologise.
No problem. But I was rather shocked to hear that it was amongst the top 10 priorities, and I would support your emphasis on the broader view across this as a challenge to everybody. It's got to be high on the priority list. You mentioned here that you've actually done a report with other bodies about the impact in places, okay? Is it possible, Chair, that report could be sent to us all so we can see the difference that the work that has happened and make a comparison in our own authorities as well? It's a kind of levelling up that I would like to see across. So if that report is out there, I think it would be interesting to actually see how that has made a difference. Or is it something that's ongoing and is being monitored, yet to have outcomes attached to it? Everybody knows that I'm one of these. Yes, I love having reports and everybody doing the buzzwords, but I equally love, and I think every report should have an addendum to it saying this is the outcome, and that way we can actually monitor how good or how bad it is. The health agenda is really part of the wider issues that you've made, James. And unfortunately, all of this has to do with authorities' resources, so it will be different across the patch. I appreciate that. Now, can I ask a last question, if I may? And I think this is in general terms to everybody involved, including Ian. How are you managing as a body, collectively, dealing with the future that's to come with the bill, which is why we're meeting here today? And what input collaboration is there between yourselves and what is determined as the reset agenda for the trusts of delivery of health? Because that is a massive, massive issue of backlog, which in itself has an effect on our community as a whole. That's their health agenda. So can you tell me how you are looking at going forward with this care bill, and at the same time, the bodies that you are partnering with and those that may be represented and will be represented on the boards, etc., they are on a path of a reset agenda. And looking at the present situation, obviously there's implications as we stand now, but where does this fit in and correlate with the reset agenda, please?
So it's the same. It's the same partners doing the same work, and what it means is that everyone's exceptionally busy. So obviously we've got a huge amount of focus on the reset work, on elective care recovery, and an example of what James was describing about inequalities. Sort of feeding through everything we do. We're doing a lot of work on the composition of waiting lists, and particularly for people who wait longer, because we know there's a gradient on people who wait longer towards more deprived groups and towards non-white groups. And so the first job is to understand that composition of the waiting list so that we can put in place things to address those inequalities that we are observing. But essentially, it's the same organisations and the same leadership coordinating the reset as well as doing the future design work. Anthony, I don't know if there's anything you want to add specifically around the reset work in addition to that. Anthony Keeley.
Yes, I can. Thanks, Ian. I'm Anthony Keeley. I'm the locality director for NHS England in West Yorkshire and Harrogate, working as part of the ICS partnership. So Councillor Rhodes is absolutely right to emphasise, the challenge, if you like, of resetting health and care services as we recover from the worst effects of the pandemic, and that's been a major focus of activity just over the last couple of months with all of our trusts and CCGs working together to develop a plan for getting back on track with waiting lists and the wider reset of services. So we've been through a process of developing those plans at place level and coming together at a West Yorkshire system level, and we're already starting to see very good progress in the, if you like, the proportion of normal activity that we're able to get back to. So if we think about 2019 has been the last full year before the pandemic kicked in, what we're keen to do is to make sure we get to the numbers of operations and other procedures being delivered that would be equivalent to what we were able to do before the pandemic, getting back to that level of activity as quickly as possible. And over the past couple of months, we've already got back to a position of around, in aggregate, around sort of 85 to 90% of if you like, those normal levels of activity, which has been a huge effort on the part of doctors, nurses, and other clinicians working across our whole system. And the plans are now in place to further increase those levels of activity in the months ahead. So it's a huge challenge, and obviously the concurrent challenge we're facing at the moment is we're seeing increasing pressures around urgent and emergency care, and of course we're seeing further impacts of COVID demand as well. So there's always a tension between doing as much planned work as possible while also having to deal with, in many cases, quite exceptional levels of demand for urgent and unplanned care. So it's an ongoing challenge. It's a significant focus of the system, and as Ian said, if you like, it's a concurrent sort of priority in terms of redesigning and preparing for the future organisational arrangements. We're doing that very much hand in hand and parallel with all of the important work around reset.
Thank you, Chair Anthony. And it's just the question from James about the reports that he's mentioned. If it's possible, it would be interesting going forward, because I know a lot of us want to see the health inequalities in its whole content getting a great priority, really. So that background information would be healthy, Chair, if it's possible. Thank you.
Yeah, it's published on our website, but I'll send Mike the link and he can send it round.
Yeah, that'd be helpful. Thank you. Okay, I'm conscious of the time, and we've got the COVID update on next. So I've got Councillor Clark here, and then Councillor Hutchison, Councillor Smage, if you wouldn't mind keeping your questions short, if you can. Okay, thanks. Councillor Clark.
Yes, thank you very much. I just have a quick question on the governance and also on the naming of the operation. The first one is in the only part of North Yorkshire that will be in the West Yorkshire. ICS will be Craven, and how are you going to deal with the governance having two local authorities? Generally throughout the country, we've tried to get this concept of place, but it doesn't work in Yorkshire according to the NHS, and I think it's a pity that we're splitting up North Yorkshire, but that's my personal view, and it was an opportunity to make change. But I just wonder how you're going to manage to get representation. You know, some people have said already they're worried that Leeds might dominate. I have no problem with anybody dominating anybody. We all work together, and we've worked very well, this particular committee. So I'd like to know how we work that. And then I'm getting a bit fed up of always calling. We're still calling the impending ICS West Yorkshire and Harrogate, but Harrogate is not in West Yorkshire. You'll be relieved to hear because it's in Humber Coast and Vale, and in North Yorkshire. You know, Harrogate had very poor governance. Everybody knows that. We had 5 CCGs that came out of the Lansley debacle. And I said on the first day they weren't sustainable, and that's been proved right. But in fact, the only one that worked was the one in Craven, which is the one that's coming into West Yorkshire, the Airedale and Wharfdale people, and working very closely with Bradford, as Councillor Greenwood knows. We've worked well in the past, but I'm worried about how the particularly rural areas of Craven will be able to be represented. And I also think there needs to be greater transparency, because I think there's been an opportunity missed here of working. This seems to be led too much by the NHS, and it's being treated as an NHS reorganisation. I've been through 5 of these, and they never really work. I'm quite happy to give this one a chance, but you know, we had 4 CCGs, and each of them were reported to the Secretary of State because they were acting unlawfully. They couldn't do proper budgets, and we eventually merged them all. And I don't know what. I'll be glad to see the back of CCGs. They were an unmitigated disaster, but there we go. But anyway, if you could answer the question, what do you think the name will be for? Will it be West Yorkshire ICS, and what will be the governance arrangements? The other thing is we're in a state of flux in North Yorkshire at the moment, because we'll know this week whether we're going to be reorganised or not. But the first thing you see with any organisation, I say this having been through 5, people are already jockeying for positions on various boards and going for interviews, and there'll be some people who will strike it rich. But at the end of the day, we've got to put the patient first. And I think that's where we've gone wrong. And the great word that came out in the when the white paper came out, it was collaboration. And I'm not quite seeing enough collaboration between local authorities and the NHS here, because the word.
I think James is desperate to come in there to answer.
Okay, yes, sure. But I think this needs to be agreed, particularly the Craven situation in relation to the rest of it, because it's out on a limb.
So Chair, thank you very much. So Councillor Clark, thank you very much. So I've as a GP that works at Craven, but also works across Bradford as well. I've seen the working relationship and has been forefront of my care of the CCG at Bradford District and Craven is ensuring that we cover all areas, and the voices of those who are in inner city of Bradford City are heard, as well as the voices of those who live out towards Settle and out in Skipton and Wharfdale there. There have been some great relationships, and we'll continue along with North Yorkshire County Council, with our district council as well. With Richard Webb, we have regular conversations. So I feel really feel as though Craven is well represented, both in terms of the CCG, which I know you obviously don't have too much high regard for, but
no, I do for the Craven CCG. Sorry, it's the rest of them.
but I do feel confident that going forward, one, it's in the foremost of our minds as a place, as Bradford District and Craven, that we represent the whole of our place, and that's whole of that Bradford District and Craven, and that we take into, and given our organisations like Airedale and our Care Trust cover, and Bradford Teaching Hospitals actually cover those areas as well. Our organisations are all aware of that, the importance of making sure we keep those relationships with North Yorkshire, and I think they are strong and will continue to be. And it's not new across the country. There are other places that have these challenges, but I would say our challenge actually, whilst it may be a challenge, is one that starts on a really good footing there. The name I will leave to Ian.
Yeah, I mean, I'll be really quick, Councillor Greenwood, because I'm conscious that we're running over slightly. So Councillor Clark's quite right in terms of the North Yorkshire CCG footprint being in Humber Coast and Vale. I guess the only thing I'd say is that Harrogate Hospital has really important relationship with West Yorkshire, particularly to Leeds Teaching Hospitals. And when you look at sort of networks for services like stroke, and maternity and things like that, it makes sense for Harrogate Hospital to have a close relationship into West Yorkshire. And that's absolutely, you know, as James was alluding to, when you define boundaries, there's always compromise involved, and you're not setting up walls around the ICS, but it's just the kind of coming up with the most meaningful footprint to do stuff on, I think. So we absolutely want Harrogate Hospital to be a close part of our provider collaboration. In terms of the name, we can feed in that point, Councillor Clark. I think it's something that we'll have to reconsider as part of the Constitution. So in establishing the Constitution, we'll have to sort of finalise the name. But if the view is that from partners from North Yorkshire and Harrogate is that Harrogate should be taken off, then obviously that'll be taken into consideration.
Okay, thank you very much for that. Now we're going to have to be even quicker, and I've got 3 hands up now. So we've got Councillor Hutchison, Councillor Smage, and then Councillor Marshall.
Yes, 2 quick questions. These arrangements are likely to spawn a whole flotilla of bodies that have decision-making powers, with joint committees of both at place level and other kinds, and their decisions are going to be binding on the rest of the partnership. For efficient scrutiny to take place and for transparency to work, we really do need these bodies to publish their agendas, hold meetings in public, and publish their minutes, so we know which decisions are being taken by whom and when, so that we can provide an effective scrutiny and overview function. I would also like to make a plea that there should be a widening of scope for freedom of information legislation to apply to all organisations providing public services. Because if these organisations are going to be involved in the decision-making process, being able to say, well, the commercial sensitivity prevents us from actually letting you know what's been happening, it'll make our job a huge amount more difficult. The other question is about workforce planning. Providers have been very keen not to get themselves too dirty with the actual training of the new generation of staff, particularly clinical training. They want fully fledged clinicians to be taken off the shelf to work from day one. But that's not how we're going to actually have a sustainable workforce. And workforce issues are one of the key problems facing the NHS. So how is the integrated care system going to actually accept its responsibility for providing a route for trained clinical staff that it needs? Thank you.
So Ian, if you can take on board what Councillor Hutchinson said, you might want to answer that final question that is just asked there. But
yeah, I mean, on the workforce point, the workforce planning, workforce leadership thing, we don't have an answer on that. Yes, I'm afraid, Councillor Hutchinson, it's something we're working through. And again, it would be useful to get a scrutiny view on the place-based arrangements being in public with published minutes and published agendas. Absolutely, 100%. That's part of the governance work that we're building in. On the question about the breadth of the scope of FOI, I can't answer that one, I'm afraid. I don't know.
okay, thank you for that. Okay, Councillor Smidge.
Yeah, thanks. I'd like to echo that about joint committees being transparent. I can think of one joint committee that is not transparent at this moment in time. So I think joint committees, etc., should be transparent. I would just come back to the reset work and your 5-year plan, and ask really that the constitutional work doesn't drown out the need for looking at services that people need, and how those need to adapt in light of what's happened and the needs that there are now, because those needs will have changed slightly, maybe, and looking at that and that not being drowned out by all of this, and agree that we need collaboration. And as I've said before, we need to find a way of looking at this whole process from the overview and scrutiny perspective. And maybe you can come back to us as well. We haven't mentioned dental services at all, and I would be interested to know how you're going to be commissioning dental services at some point. But obviously, we'll need to come back to that. Thank you.
Yeah, all good points there as well. So that's something that. Councillor Marshall.
Thank you very much, Chair. And I would like to say thank you to Councillor Rhodes for eloquently putting across how I feel about the health inequalities and why it is very important that it should be prioritised. Ian, in your slides that you were showing through when you were referring to the inequalities as well. So there was reference to disability, there was reference to gender. I will be very interested in reference to ethnicity, obviously, with what we have seen, especially in the last 15 years, 15 months, you know, with the death rates, especially people from Black and Asian backgrounds. We're also getting reports about maternal death rates with the Black and Asian woman 4 times more likely. So these are the inequalities I hope we would have in the report that you will be sending through to be able to help us work further with yourselves on how we tackle all of these.
Yes, you're quite right, Councillor Marshall. I mean, we showed 2 slides there to show the sort of the inequalities. We could have showed 30, you know, and because it applies across all of the you know, characteristics you can imagine. So you're quite right on that. On the race inequalities issue particularly, we did quite a lot of work last year through a panel chaired by Professor Dame Donna Kinnair. We produced a report. We've produced an action plan in response to that. And we take that action plan to every meeting of our partnership board. So we've got a quarterly update on the work that we're doing specifically on the race inequalities issue and the sort of the diversity and leadership issues that we've also got across the system. So again, I can share those reports with you because I think they demonstrate quite a lot of work happening across the system.
Okay, that's really good. Thank you. So while we finish off with the new members of this committee, I, as chair, wrote to the previous Secretary of State, voicing all our concerns about this bill, some of which probably haven't been mentioned today, like the removal of the referral powers to the Secretary of State, which I think is a really important one that we need to speak up about. Unfortunately and disappointingly, we never got a response. Now we've got a new Secretary of State, so possibly it's got lost in the ether somewhere, I don't know. So what I want to ask members here is, do you want me to write again specifically to the new Health Secretary, Sajid Javid? Probably the same letter because the same things apply, don't they? So would you be happy if we did that?
And I love that, Chair. I think it's very important. We keep pressure on to letters that we need answers to.
Yeah, definitely. I agree. Okay, right. Well, we'll sort that out. That's great. Thank you for the officers coming today. I think that were a really good item, actually, some good questions and some really good answers. So we'll call this item to a close now, I think, and move on to another big one that we've got, which is the COVID update. And we've got Tony Williams here. Hi, Tony. To give us, I think you've got a verbal update and some slides, haven't you?
Councillor Greenwood, can I just introduce Pat Keane as well, who's who works on urgent emergency care across the ICS as well, who's got a few slides as well after Tony, if we've got time.
Yeah, sure.
Great, thanks, Councillor.
Hi, Councillor.
Hi.
Okay, that's great. Okay, do you want to introduce yourself, Tony, as well?
Thanks, Chair. Hi, so I'm Tony Williams. I'm a consultant in public health and I work for Public Health England in Yorkshire and Humber. And as part of my remit around COVID, I've very much been providing advice and support to the West Yorkshire system. I'm just going to attempt to share my screen, so just bear with me. So I'm hoping you can see those slides now. So apologies if some of this you already know because it's very well highlighted in the media, but I just thought it'd be quite useful just to give you a bit of that national context before we look at West Yorkshire. So as you'll be aware, cases of COVID continue to rise and they're rising pretty rapidly, as you can see from the slide there. And that rise has really been evident since step 3 of the roadmap that came into play around mid-May. And of course, since then, we've also had the emergence of the Delta variant, which we know is much more transmissible than the previous Alpha variant. So where we are at present is we're approaching around about 50,000 cases a day in England. And over the last 7 days in England, we've had 240,000 cases in that last week. So that's a rate of around 426 per 100,000. And what I want to kind of really highlight on this graphic that you should be able to see is just where we are now compared to previous waves. So if we exclude the first wave last spring, because we weren't testing in the same way as what we are now, this wave in England is significantly higher than the autumn wave when we had the November lockdown, and it's approaching the same kind of level of infection that we had when we went into the January lockdown. So you'll remember that was a really long, hard lockdown in January. Now, rates vary across the country. All parts of the country have high rates and all parts of the country are seeing their numbers going up. The Northeast in particular has high rates, but that's also followed by Northwest in the Northeast. And that pattern where we see higher rates in the north of the country compared to the south is something that's been consistent throughout the pandemic. And it links just back to what we've been talking about there around health inequalities. In terms of the rates and where we're seeing the highest case rates, it is very much in younger adults. So, for example, secondary school age children, so that 10 to 19 age bracket, and also the 20 to 29 age groups. And that again is being very well publicised with the school bubble system in the media. And it's not a surprise that we're seeing case rates high in those groups. So there's a lot of social mixing in those age groups. And of course, it's only been recently in terms of when the 20 to 29 age group or the over 18s have been able to come forward for their vaccine. So lower vaccine uptake in that age group and less likely to have received 2 doses of the vaccine. So I'll just move on. So what's a little bit different about this wave is what's happening in hospitals. So whilst the case rates are approaching what they were in January, you can see that the numbers of patients in hospital as a result of COVID is not the same. It's much, much lower than it was in all of the previous waves, in fact. But it is starting to go up. You can just start to see throughout July, the numbers in hospital is going up, but at a much reduced rate. And that is around the vaccine uptake, the high vaccine uptake, and the vaccine starting to weaken the links between infection and illness. And it's very, very similar data with the deaths. So we've had a very, very small increase in the number of deaths within 28 days of testing positive throughout July. But you can see very, very clearly that the very high case rate has not yet translated into a sharp rise in deaths, thankfully, and thanks to the vaccine campaign. So just moving on to what's happening across West Yorkshire, and I should just say all this data comes from the UK COVID dashboard, so it's all publicly available. So the pattern that I've described nationally is replicated in West Yorkshire, and it's actually replicated across all 5 local authority areas. And you can see since the beginning of September last year, very, very similar patterns actually across all 5 of our places. Across the last 7 days, just over 12,000 people in West Yorkshire tested positive for COVID. And our rates are currently between 400 and 700 per 100,000 population. So similar to and above what we're seeing nationally. And you can see just, I think, quite how sharply those rates have risen throughout June, really, and coming into July. I don't really want to dwell too much on differences between different local authority areas because the speed of which the rates can change. And you can see Wakefield, which has traditionally been, I suppose, at the lower end of the West Yorkshire rates, has risen very, very quickly over the last 3 to 4 weeks, and it's now, you know, approaching 700 per 100,000 there. So again, I think the key thing that I want to note here is just how much higher our rates now are compared to January when we went into that lockdown. Some areas are approaching double the rate, some are just above. And autumn for us in West Yorkshire, that was when we had our really kind of biggest peak since the springtime. And you can see that the numbers are going to be higher than the autumn and the January waves. So again, just highlighting what is different, and I'm sorry the slides are quite small, but just to show, the light blue line is the case rate in the under 60 population, and the dark blue line is the case rate in the over 60 population. And in previous waves, what we've seen is the case rates have basically tracked each other regardless of age group. But what we're seeing now in this 4th wave of infection is something very, very different. You know, the case rates are significantly higher in the under 60 population compared to the over 60 population. And we split it up in this way just because, you know, the risk in terms of having a severe COVID infection that may lead to hospitalisation and severe illness, it goes up with age. I think it's important to be really clear. We are seeing rises in rates in the over 60s. You know, the vaccine is having a massive impact, but we are still seeing rate rises in the over 60s, but much, much smaller, thankfully, than in the other age groups. And in terms of the impact this is having on hospital admissions, this is really, really clear. So this is data across our 5 hospital trusts for all 4 waves of the infection. And just to draw your attention to the very far right-hand side of each of those graphs. So you can see that we're starting to see the number of people in hospital as a result of COVID rise from what was actually a very low level when we came out of the 3rd lockdown. But again, we're not seeing the levels of hospital activity for COVID-related illness as we were in the previous 3 waves. But it is starting to slowly creep up. And that's what we would expect, especially with the rates, what they are now. I think the number of people in hospital with COVID in West Yorkshire is around 14% of what it was in the November peak. And similar to the national picture, the number of deaths that we're seeing at this time of year is probably below what we would normally expect at this time of year. For COVID deaths, it's around 5 to 10 per week. And that level has been pretty much maintained since we came out of that 3rd lockdown. And these are the lowest levels of deaths that we've had since last summer. So again, the very, very high infection rate isn't translating into a higher number of deaths. And I'll just quickly mention before I finish on the vaccine programme, clearly it's been hugely successful and we're seeing the impact of that in terms of hospitalisations and deaths. Over 1.5 million people in West Yorkshire have had their first dose, and over 1.18 million have had 2 doses. So, you know, good uptake, and efforts continue to make sure that those who haven't had 2 doses come forward to receive them. And I'll leave it there. Thank you, Chair.
Thank you for that. That was really interesting. Now, Councillor Clark, you've got your hand up, but I'm feeling it's from the last item and you've not put it down, or do you have a question on this?
No, I'll put it down. It's okay.
All right. Thank you. So, Councillor Hutchinson then.
Thank you, Chair. Can I ask about the beta variant of the coronavirus? Because that is far more likely to evade the benefits of vaccination than the Delta variant. How many cases are we experiencing within West Yorkshire at the moment? What are they following any particular trend? And if they do start to take off, have we got plans in place to be able to stop that? Thank you.
It's a really, really good question. And I think, you know, that's what everyone's concerned around is around new variants. So there are a number of variants that we are monitoring very, very closely. Some variants are termed variants of concern, and they get closer monitoring. Then there's a package of interventions that go in place when we detect cases. And then there's variants under investigation, which are more closely monitored, but we don't have the same package. So I'll speak more generally about variants of concern, if I may, and then I'll pick up the beta question. So when we do get these variants of concern, when we do detect them, and we are pretty good at detecting them, you'll be aware that we have some of the best surveillance capacity within the world around genomics. When we do identify them, there's enhanced testing, enhanced vaccination. We go do door-to-door testing. We actively go looking for them. In terms of the numbers specifically around beta, I don't have those to hand, I'm afraid. I could get those for you offline, but I don't have them to hand. But what I would say is that the Delta variant is very much the dominant variant in West Yorkshire, as well as the rest of the country. And we saw a very, very rapid change in terms of the variant circulating. So we went from Alpha, which was the variant that first detected in Kent, to Delta within about a 4 to 6 week period. It happened very, very quickly. Of course, all variants are important, but actually it's almost the strongest variant that is the one that dominates, because actually that's the one that matters, because that's the one that takes over very, very quickly. We aren't seeing that same pattern with beta. It's very much around Delta. Clearly, the worst case scenario would be a variant that had vaccine escape. But actually, we haven't actually seen that yet. We've seen all of the variants that have been circulating. The vaccine has been effectiveness to varying different degrees against them. So I don't think at this stage we're thinking it's not a black or white scenario. The vaccine will work or not work. And it's also really, really difficult to get a handle of how effective a vaccine is in lab settings compared to real world. So you can do a number of lab tests to look at how antibodies neutralize different variants, but actually it doesn't replicate what happens in real world settings, because the immune kind of response is much more complicated than that. So what I would say is, just to summarize, there are plans in place for dealing with any emerging variant in terms of that surge kind of testing capacity and surveillance, and then obviously monitoring around the impact of the vaccine. And, just to highlight that, we obviously want to bring infection numbers down, and that has to happen globally. That's our best protection against the emergence of new variants, because this is what viruses do. They change all the time.
Apropos of that, Public Health England haven't really widened the publicity of the symptoms that people get with COVID. I'm on the local authority contact tracing team, and with the Delta variant, the commonest symptoms are headache, fatigue, muscle ache, and blocked nose. Now, those don't actually feature on the symptoms that are being publicised. So if we want people to come forward and be tested, we have to let them know what the symptoms are of the disease. Otherwise, they'll spend days until the penny drops. Why aren't we actually broadening the clinical definition of COVID?
So, Councillor Hutchinson, I probably can't answer this as clearly as you would like, because ultimately that is a decision for the Chief Medical Officer. He is the one who would approve any change to the definition of symptoms that enable people to initiate a PCR test. But you're absolutely right. There is emerging evidence from a range of different sources about different kind of clinical presentations around the Delta variant. Now, I'm not sure if that's because it's a different variant and it presents in a different way, or if it's about we're seeing more cases in younger adults and children and therefore presents differently in them, or because we see a small number of cases and people have had the vaccine, so they're naturally going to get a milder illness. So all I can advise from a public health perspective is, if you're not feeling very well and you're thinking COVID, then you should be booking a PCR test. I know I appreciate that it's not as clear as you would like it to be.
Okay. Councillor Marshall.
Thank you, Chair, and thank you, Tony, for your presentation. Like you've said, the rates we have at the moment and in that age gap between, the younger adults between 16 to 18. Now, the government is proposing vaccinations for 12 to 15-year-olds and some months before 18. I mean, what is the rationale between some months before 18? What does that mean? That is just very confusing. If you're going to be vaccinating 12 to 15, so what's the what's the clinical justification between 16 to 18-year-olds that you're saying 3 months before their 18th birthday? Could you kindly explain that to me, please?
Yeah, so there's two bits in there. So the announcement yesterday around the 12 to 15-year-olds, that's not all 12 to 15-year-olds, that's only in certain specific circumstances. So for example, if the child had a condition that made them more vulnerable to the consequences of COVID. So if they caught COVID, they were more likely to get a severe disease. Or if those children live with a vulnerable adult and, say, for example, a clinically extremely vulnerable adult. So if the adult was to be exposed to COVID, it would have, quite serious consequences. So the guidance around the 12 to 15-year-olds is in a set of circumstances. The 3 months before 18, obviously, because for 18 and above, those individuals would be invited for the vaccine as per the programme we have right now. I think it's just widening it to recognise that, it's almost like an arbitrary cutoff, when do you turn 18, when do you get it? And I think it's just bringing that forward slightly so that more people can benefit. But I think, these decisions that the government acts on independent advice from the Joint Committee for Vaccination and Immunisation, it's scientific advice and independent. The decisions made around children and vaccination are really, really quite complex. So for adults, the consequences of, a COVID infection, as we know, could be very, very severe. For children are much, much less likely to get sick, often, very, very mild, if symptoms at all. So, the benefit to children and young people of the vaccine is different to what it would be for an adult. And therefore, it just makes that decision about whether we want to vaccinate children and young people just a little bit more difficult. But we've obviously had that announcement yesterday, which takes us a little bit further forward.
Right, thank you. But if the rates that you're telling us now are highest between 16 to 18, and we've got Freedom Day yesterday, these are the young people who continue to be around spreading it. So why is that 16 to 18-year cohort not being vaccinated?
So I can't answer the why, I'm afraid, because again, it's a government decision based on independent scientific advice. So something I'm not involved in, but I suppose if I could try and convey some of the rationale, generally it's because, we talk a lot about cases, and very high case rates, but that's not the same as illness and disease. We don't vaccinate children, people against, rhinovirus and a range of other kind of really common mild illnesses because we don't cause severe illness. So what we have, and I appreciate it's quite difficult to see these rates, in children and young people. What we have is a virus that currently is spreading rapidly through that population, but it's not causing significant levels of illness in that population.
Okay. Pat, did you want to come in at any point? Have you got anything you wish to add to all that?
I've just got a few slides, Chair, just on pressures. I don't know how much time we've got.
Well, if we just go to Councillor Smage first, because she's the last one with the hand up, and then we can come to you on slides. Is that okay?
Of course it is.
All right. Councillor Smage.
Yeah, thanks. I just had a couple of questions actually about the testing capacity and how that was coping. And also the vaccination programme, how on a West Yorkshire basis you're going to be adapting to try and encourage more people to come forward if they haven't already, and how to encourage people to have the second dose. I know some people might have had the first dose, but we need that message that people need the second dose as well. And will there be any changes in vaccination centres? I'm not talking about the pop-ups, I'm talking about the static ones. Are there any plans for changes there? And how are your plans for the autumn boost coming along? Thank you.
So, Councillor Smith, I'm sorry, I probably can't answer a number of those questions just because the vaccination programme is an NHS responsibility. So it's something that the NHS roll out rather than a public health responsibility. I know it probably seems a bit counterintuitive, but I can answer a couple of them and I'll have a go at. So rather than the operational ones, I'll go for encouraging vaccine uptake. So as you would expect, a huge amount of work going on, you know, at place-based level, at West Yorkshire level and nationally around doing everything we can to promote vaccine uptake. Huge focus around young people, because obviously they've recently been become eligible. I think without getting into specifics, there's, you know, we have seen activity around using youth champions, very much it being led by local communities, that community voice, rather than, you know, someone like me saying, oh, you should get your vaccine. So I think it's, you know, it's that place-based work, and I think is a, you know, really strong feature of what's happening in West Yorkshire, and all 5 places are doing work on that relevant to their local population. And there is a West Yorkshire Health and Equalities vaccination group which coordinates that work, shares learning, and also from my own organisation's perspective, we have provided support and training, for example, around behavioural insights and that nudge theory, and using all that science and evidence to eke out every last vaccination that we can. And then there's a community champions, so all areas of community champions, and obviously we've been using them. So very much community led, I'd say there. And then the testing. So yes, so far testing capacity is actually holding up. I know there've been some media reports around some of that. We are maintaining very high levels of testing in West Yorkshire. They're the highest we've actually had throughout the entire pandemic. I'm certainly not hearing any major issues at present. But we do have times, you know, where it is more difficult. But generally speaking, I think the testing capacity is holding up.
Okay, thank you for that. So, Pat, do you want to share your slides?
Yeah. Colleagues, see those?
Yeah.
Okay, I'll go from the beginning. Okay, thanks everybody. So just my introduction, my name's Pat Keane. I'm the Senior Responsible Officer for Urgent Emergency Care across the integrated care system, and we're coordinating a lot of the work that's going on at the moment. So just, I'm conscious of time, but I think just in the context of some of that earlier discussion, we have started to see in the last 4 weeks exceptionally high levels of demand in all places and sectors across West Yorkshire. This has been replicated nationally, but particularly in the north, east and northwest. So we're seeing accident emergency improvement, demand in primary care, ambulance services, community and mental health right across the board. Increases in A&E attendances, particularly driven by children and young adults, children between 0 and 5 and young adults between 20 and 29. And one of the issues to highlight there is that in the last year, we've had lots of children between 0 and 5 who've been isolated, have been at home, who've been with the mums and dads who haven't been out circulating. What we're starting to see, unfortunately, is a significant increase in respiratory conditions that we wouldn't normally see happening until the October, November time. So we're starting to see significant increases in young children presenting either in general practice or in emergency departments quite ill with respiratory disorders, and that's starting to have a significant impact. Alongside that, and I think the issue that we're seeing more than any other in this current environment is the staff absences because of TTI, because test, trace, and isolate. Up in some sectors, between 10 and 15% of staff are absent at the moment. There has just been some guidance that colleagues may be aware of, that members may be aware of, that came out recently about the ability to follow an algorithm about vaccinations, self-testing, etc. But at the moment, that's a significant issue for us. And unfortunately, as Tony said, we are starting to see an increase in the numbers, and actually the numbers of admissions are now starting to approach the January peak. Obviously, as we've said, helpfully, the impact has been mitigated by the vaccine. But for example, as of last week, we had 175 patients in West Yorkshire hospitals, and I understand that number has gone up. All places agreeing local actions to manage mitigation and pressures. We have, because we work as a system across West Yorkshire, we've re-established our West Yorkshire Strategic Health Coordinating Group. So that meets on a weekly basis, and that shares issues and actions across all the sector, the trusts, mental health, CCGs, etc. And we have also an organisation, the West Yorkshire Association of Acute Trusts, and they've stepped up their goal command escalation. That basically means that all of the acute hospitals across West Yorkshire, their chief operating officers meet 3 times a week to talk about mutual aid, shared escalation processes, to make sure that we're making best use of capacity, but also that we're actually identifying across the system where the pressures are. Just a couple of slides on activity. So this is on 999 demand, and you see the on the left-hand side there, compared to the last 3 years, the increase in activity over the last few weeks, and we've actually seen significant peaks, well over 25,000 calls compared to sort of the normal between 18 and 20,000. That's caused significant pressure on the ambulance services, both on a 111 call perspective and 999. And with the 999 calls, we are actually seeing an increase in the acuity and the illness of patients. We believe some of that, not all of it, is associated with unmet demand associated with strokes, heart attacks, etc. So that's the 111 position. So of course, this is people who are phoning up for advice or access to services. And again, you can see that spike in activity. This is a national picture, but this is replicated across the Yorkshire Ambulance Service and North East Ambulance Services. And as you can see, actual demand was up by 25% in the last few weeks. A&E attendances, again, that's the picture across all of the acute trusts, and you can see overall that rise in attendances since May, and it's gone up, and we're actually seeing record levels of attendances in many A&E departments. We're not seeing an increase in the conversion rate, so the ratio is staying the same, but because we've got more people attending A&E, we're seeing that mix of younger people attending, as I've said earlier, that high level of children attending with respiratory problems. So that's causing significant pressures across the board. So we're seeing that, and of course at the same time, we're seeing that recovery. Quite rightly, we're focusing, and we've started that elective work again. But the difference between, I suppose, the last 18 months and now is we've seen the increasing activity in ED and urgent emergency care services. We're seeing that demand. We're also seeing the signs of young children becoming ill, not with COVID, but with other diseases associated with transmission. And also then that significant impact on staffing, which is why we've got that system pressure. So it's certainly not all associated with COVID, but bring COVID as one of the areas that's affecting us in terms of, if you bring all those things together, that's where the pressure feels like. So just an example of each system is pulling together system reviews, summits, looking at ways that we can cope with this in individual places, but also across West Yorkshire and Harrogate. Clearly, a key element of this is bringing our clinicians together across the acute sector, primary care, mental health services, and we have a clinical forum across the ICS. They met on the 6th of July to discuss and review all of the factors that we think are starting to have an impact. And we've came up with a number of areas that we're actually now beginning to focus upon. I won't go into a lot of detail, but we're calling them key lines of inquiry. Why are we seeing that significant rise at this time of year in the middle of summer? We would expect to see some of these issues in the winter, but certainly not now. So we want to understand children, young people demand. We understand some of that is associated with spiritual problems, but it also could be associated with young mums who are feeling concerned and worried that the symptoms between respiratory disorders that children are presenting and COVID are very similar. So understandably, that's causing a lot of anxiety with parents. So we're doing a lot of working with local authorities and others to try and get to educate and give information to families. We're looking at the impact of proactive management. Have we seen an increase in the impact of long-term conditions on people that would normally have been seen? Do we understand that actually now their conditions are getting worse as a result of that? We're certainly seeing a high level of low acuity mental health people presenting with anxiety and depression. Those numbers are going up. We're actually trying to get a handle on how we actually manage demand for urgent care with the failure of long-term conditions. So we're having a lot of conversation with primary care at the moment around that, and maximising our partnership working with the voluntary sector. This is not the voluntary sector providing service, but we've got a lot of good relationships. They outreach and they work with local communities, and they're helping us to understand particularly some of the issues about low-level mental health and substance misuse. So we're seeing an increase in those pressures. The second is about communication, and we've touched upon that, Chair, in some of the last conversations about this is not criticising the public. This is actually understanding the anxieties and the demand that's out there at the moment, and how do we provide assurance, but also can we increase the way that we signpost people, and particularly with I gave an example of children, with engaging with parents and teachers, particularly over the last few weeks, about providing assurance around some of the symptoms that children present, and dealing with issues that normally children and parents would deal with at home, but perhaps with the levels of anxiety, we're seeing more parents phoning 111 or presenting children at ED. And lastly, considering how we approach clinical accountability. Can we make sure that clinicians are working collaboratively in relation to discharge arrangements, primary care working with secondary care, senior opinions? So basically, when people do pitch up at ED or urgent treatment centres, have we got the right decision maker that can resolve the issue quickly and ensure the person is actually dealt with in the best way, and then taking a collective approach to clinical risk. We are concerned with the pressure on the system at the moment, and we don't feel like we've reached the peak of this set of issues at the moment. And we're constantly in conversations about what the risk is around very ill people in hospital who are requiring discharge. Being in a hospital might not be the right place for them, and actually could increase risk. So we want to make sure that people are getting in the right environment, the right place at the right time. So it's just, Chair, to sort of just recognise those challenges at the moment. I must emphasise, COVID is one of the elements, but I think what we're seeing at the moment is a set of factors coming together, which is why certainly in West Yorkshire and Harrogate at the moment, we're feeling significantly pressured. We're doing a lot of work together on them, but we just wanted to flag that up there in the meeting this morning. Thank you.
That's great, thank you. If I can ask a couple of questions. In terms of the number of children that are being referred to hospital and admitted into the hospital, do you have any more detailed information on that, such as what communities are they coming from? Have you got a breakdown of ethnicity? Are they from deprived areas, or is it just a general? If you don't know the answer, that's fine.
We're certainly looking at that, Chair, because we want to understand, because we've got a lot of good data at a local population level. We're certainly seeing, yet again, I think there's been a theme throughout, Chair, the correlation between those areas where we've got health inequalities, and we've got those hotspots. But I think across the board, we're seeing children being referred right across the piece, and I think that relationship between COVID, clearly what we've heard, there isn't very young children do not become ill with COVID. But actually, if you're a young mum and you've got a child who's got symptoms similar to that, you're going to be worried and you're going to be concerned, and you're probably going to be wanting to see a face-to-face appointment with a GP or go to ED. But we can certainly get access to that data, Chair.
We're also hearing, hospitals don't need to worry, they're not going to be overwhelmed, there's not going to be extra pressure. And I understand that some hospitals are actually writing to the government saying, whoa, hang on a minute, we are really genuinely worried about this, and we do feel that this is pressure on us. So, can you just take that into consideration?
Yes, I suppose that, yeah, Chair, so I think the narrative about COVID, as we've seen, in itself, we're not seeing that impact, but I think there are, as I've said in the slide, there are a number of other factors So certainly in the NHS at the moment, we feel significantly pressured. We're dealing with that, but I think it's that perfect storm, if you like, of coming out of COVID, public anxiety, unmet demand, staff absences. That is a significant factor for us, because we would normally rely upon where we've got a more able staff for asking people to work extra shifts. So staff are tired. We might offer premium rates, but many staff are unable to take that, and that's not a criticism. So I think that staffing absence issue laid on the others is one of the areas that's causing us a lot of concern at the moment.
So thank you for that. We've got Councillor Rhodes waving a hand there. So Councillor Rhodes. You're on mute, Councillor Rhodes.
All right, let's try again. Yes, can you hear me now? Hello?
Yes, we can, Councillor.
Okay, thank you. I'm having difficulties. I'm in and out. Vanda, you were having great difficulties with your mic. It was like one of these old compares at the Working Men's Club. But anyway, love, I think we got the gist of it. One or two things. Hello, Pat. Nice to see you.
Hello, Councillor Rhodes.
Hello. First of all, I've had a report sent to me about ambulances queuing up at Pinderfields Hospital, and over this weekend, 4 hours ambulances queuing up outside, and some of the ambulances, in terms of even the previous week, having heart rhesus patients on board, having difficulty getting through to the hospital. Is this a consequence of a reduction in any beds that's needed for such as rhesus patients? But as well as that, is this a consequence of either A, staffing levels, or B, the situation of ambulances? The question is, are they being prioritised as they're queuing up at the hospital? Secondly, I only saw a small piece of what seems to be the way forward as far as the government is concerned, in terms of staff who are pinged and have to be off, which is causing obviously grave concerns to yourselves and other care elements out there in the community, as well as other establishments. And I believe, and correct me if I'm wrong, and this brings on board our public health colleague as well, I believe that what I heard, and it may not be all the picture, is that the system that they're being looked at the moment is those nurses and care elements as well that have been pinged to go off staff, to go off work, are now going to be considered, if they've had the double dose of vaccine, to be enabled and confirmed through public health to return to work. Do you have any update on that one, Pat?
Yes, Chair. Some national guidance on that one
as well.
Yeah, James, did you want? I see James. Did you want to come back on that, James? I know James has got his hand up.
Yeah, hi Pat. Thanks. So you're right. As Pat mentioned in his presentation there, so some guidance came out yesterday, and that was specifically from NHS England, and it's kind of asking us if we are pinged to self-isolate, is to get a PCR test post-exposure. If that's negative and we have no symptoms as a clinician, and we then do our negative lateral flow test going to work, then we are able to go back to work, which is different from what the previous guidance was. So it's about getting a negative PCR test, and if you have no symptoms and you do lateral flow. And the guidance has suggested that each organisation, and that could be a trust, it could be general practice. So size difference will have a infection control lead, and through that lead or the senior leadership in that organisation will help make sure they aligns to the guidance that's come out from NHS England, and they can bring in the leadership from the public health local authority and the CCG if required to help them with that guidance. I'm thinking specifically for smaller organisations like GPs and GP practices there, if there's any issues there. Is that right, Pat? That's
spot on. Thanks. And on the other question, Councillor Rhodes, There's been no change in the clinical criteria associated with ambulances arriving 999. What we have seen, as I've mentioned, is significant ED attendances. In fact, Mid Yorkshire has had the highest levels of attendances in the last 2 weeks on record. That's right across the board. So there's a combination of the number of ambulances, the number of 999 calls that ambulance services are receiving where they've got to transfer people to ED, then the pressure on EDs themselves, then that pressure on beds. The number of beds hasn't changed. Obviously, we converted back from red and green because of the lowering of COVID. We are now hospitals are now having to look at reinstating red and green areas. So in other words, COVID positive and COVID negative. That'll be an additionality around the capacity issues. So yes, the ambulance service has been extremely busy over the last couple of weeks, and that is one reason why lots of ambulances arrive. They're then the backup in the hospital in terms of the number of appointment and then the access into beds. So we've been aware of that. We've actually got we've had several meetings with Yorkshire Ambulance Service. Again, unfortunately, they're call handlers, so they've got between 50 and 20% of their call handlers absent at the moment as well. So again, that factor's playing on, which is why this guidance is welcome. Clearly, we'll need to make sure that we adhere to that guidance and that we do not want to put patients, the public, or anybody at risk. And it's again weighing the balance of risk. But at the moment, with the significant levels of absence that we've got, we have real concerns going forward about sustainability if we don't get staffing back in the system quite soon.
Thank you for that, Mike. Can I just add to that, if I may, in terms of picking up on Colin's point earlier on about the messages going out there. A lot of people, and you see them on television, I hear about them constantly, who've had the 2 jabs. The message going out is, well, I don't have to bother because I've had the 2 jabs. And they think they're fully protected, which is not the case. It's not the case. They can still actually get the virus, the awful virus, but obviously it's not going to be as bad. And I think the message going out there has got to be reinforced about we're all aware of the efficacy and what's been going on and all of that. But the message going out there, there's too many mixed messages. There's communications that are fully not communicated and understanding to the general public. And I do believe that in terms of public health and everybody else, we have got to be really pushing the point to people who have had the double jabs that, yes, you can still get infected, but it will not be as severe as before the injections, because we're countering the situation of how good the situation is with people thinking, I can go out, well, God knows what's going to happen after yesterday. We won't go there, but this is a message that's coming across from people who have had the double jabs. I'm free, I can do what I like, and I don't have to be preventative in my actions. And that does worry me. To everybody involved in the health agenda, I please keep reiterating it, because all we're hearing about now is, yes, we are aware of the impact on the young people, but the older generation who've gone out think they are immune 100%. Could you actually hear me, Pat?
Sorry, did you? Couple of things, Chair. We are guided by national guidance, national policy. We have to adhere to that. What we are doing, I think you may be aware, members may be aware that from an NHS perspective, there's guidance coming out. We will continue to wear face masks and PPE in any NHS setting, and we will ask patients and or visitors who come to any of those environments to wear face masks. And that guidance is that's come up for the till the end of September. And we will obviously, through any forums that we have, we strongly encourage, we reinforce the fact, because we must remind ourselves that the clear message from the beginning was that any vaccine, not just this vaccine, does not have 100% efficacy. We know that these vaccines are very good. They have good coverage, but the other statement always was that it will not offer you immunity from getting the disease. What it will do is have an impact upon your symptoms, which we are seeing. Thank goodness we are seeing that playing through. But absolutely would reinforce those messages that the vaccine is a fantastic thing, but it doesn't make you fireproof from getting COVID. and you just got to be aware of that. I think it's a difficult one, isn't it? I think in terms of the messages to the community, but where we have the opportunity, we reinforce the public health messages that have been out there from day one about get your vaccine, take your vaccine, but be cautious, be aware of the opportunities for spread, within the community. And so we would certainly encourage, although it's not legislation, we would encourage more vulnerable people to wear masks, to be careful. That's clearly something that's an individual choice, but certainly in the NHS and healthcare sectors, we are maintaining that guidance around PPE, social distancing, and wearing a face mask.
Thank you very much, Chair. Thank you, Pat. We'll keep getting that message out as well. Thank you.
Thank you. Councillor Hutchinson.
Thank you, Chair. The vaccine is only effective against COVID. During the winter, we saw a very welcome reduction in the incidence of norovirus, leading toward closures and other things, presumably as a result of the hygiene measures that were brought in with the safety regulations. I believe that norovirus outbreaks are increasing across the country. Is that affecting West Yorkshire? Because closure of wards at this time when they're under such pressure would definitely not be a good thing. And what are we doing to try and make people aware of the protective measures they need to put in place?
Thanks, Councillor. So exactly the same measures that we've taken, that we've put in place for COVID, which is why they've had the impact, which is all about IPC, good hygiene, hand washing, proximity, exactly the same principles that we have in place. And as you rightly say, we flu was not a factor last year. No, unfortunately, not in significant fact. We are seeing a small increase, but again, it's exactly the same messages to staff and the public about good hand hygiene, about if you do feel ill, stay at home. Norovirus particularly is a very, very contagious. And so obviously if there is an indication that we have any outbreak, the public health teams come into the hospital or whichever environment it is and rapidly do tests, and we instigate closure of wards, etc. All of that good IPC stuff. But yeah, absolutely, and that's one of the issues for us going forward. We know I know that we're hearing nationally about flu vaccine coming out the same time as the boosters. It's really, really important, and those public health messages will be coming out about all of the principles that we've got in place about good hygiene. We should be doing all of the time. I know there's a debate and a freedom issue about masks, and I get, but in terms of hand washing, proximity, cleaning afterwards, etc., those are all things that we should be doing routinely as a population. And unfortunately, we don't always do either, but we certainly in any healthcare sectors, we have experts who advise on all those issues, and we're very, very clear about our expectations about IPC within those environments. But there's no doubt about it. I think, given that we now haven't got, we've had that, if you like, releasing generally, the impact for us is that we maintain that focus, whatever the sort of disease process is.
Councillor Smage.
Yeah, I've just got a really quick question because time's getting on, isn't it? And it was just, you said you're working with primary care, and I just wanted to check about access, because obviously if there's access problems in primary, then it's going to impact on secondary, and especially if there's extra staff pressures with people not being able to work because they've been asked to isolate. So are you discussing access to services so people don't feel that they can't go to certain places to get help, so that we're not creating more of a backlog? Thank you.
Yeah, we're trying our absolute best to do that, but I can see James has got his hand up because it's a really important issue, I think, for members of the public about access to general practice. James.
Yeah, thanks, Pat, and Councillor Smage. Absolutely, is paramount access to any healthcare kind of advice and guidance and assessment there. And I think it's about how we approach it from a kind of gearing up approach across our system. So we have lots of different approaches into supporting people with self-care, whether it's through websites, whether it's through our communities, with our community pharmacists, then general practice as well, and then obviously access into kind of specialist areas and the acute services. I know primary care, lots of discussions going on in places with my colleagues in general practice about. We know that access has changed over the last 16 months in terms of general practice, and in terms of ways have significantly changed. Digital, using e-consults in terms of getting access to the telephone, and also continuing face-to-face. We know there are challenges, and there are challenges in terms of the number, the demand, and the need as well there, and into general practice. And we know that at any level, whether it's in community pharmacy, whether it's in general practice, having challenges to access only means that people then go the next step up, which may not be appropriate. Therefore, that's where you see some of the need and demand ending up in kind of our emergency as well, which is probably not the right place for some people there. But it's not because of their lack of not trying to find access elsewhere. And so there are lots of discussions going on across all our places to how we improve that, how we can get that access for these people. And as I said, it's not just into general practice; it's also into access into self-care. Have to say, as a GP, access has always been an issue. It's not new in terms of this. I think it's just highlighted the issues, and also with the changes that have happened. And some of those changes have been very good. As a practicing GP, I know in terms of I can get through so many more people and have those contacts with people through the telephone, that I'm making sure I get the right people in to see. But I know that's not always easy. I know there are challenges with that as well. And so again, it's looking at how we can do this better. And also going back to kind of what Pat said earlier on in his presentation, about how we can be more proactive, so that we're not seeing people when they are in their acute, or we see them in a more proactive way to prevent them from pitching up in the worst state or in a more acute state, and how we can be more kind of proactive in terms of giving them management plans to help them with their self-care. But I appreciate it is a challenge.
Great, thank you very much for that. That were a really interesting item as well. So thank you for coming, and we'll end that one there. Obviously, you're more than welcome to stay. But
I'll go. Thank you, Chair.
All right, thank you. Right. So the next item then is review terms of reference. So over to you, Mike.
Thank you, Chair. I hope this will be very brief. The scrutiny officers that support the health scrutiny in each of the 5 councils have met, and we've had some terms of reference for a number of years now, and the officers felt that they probably needed some revision, particularly in light of the bill and presumably subsequently the Act, to make sure that your terms of revision make sure you can complete effective scrutiny under the new arrangements. So with your permission, the group of officers will get together and we'll work on revised terms of reference with a view to bringing them to a later meeting of this committee as a draft, so that you can see them and see what we're suggesting, so that we have a set of terms of reference for this body that reflects the new legislation and what you want to see in terms of your own role, and we will bring that either to the first meeting of the next municipal year or the meeting before that. Thank you, Chair.
Yeah, that's fine. Is everybody okay with that? Yeah, that's great, Mike. Yeah, thanks. That's agreed by everybody by the looks of it. Yeah. Okay, so we're still with you then, Nightingale Hospitals.
Yes, thank you, Chair. You asked for an item on Nightingale Hospitals, and Steve Russell, who is the Chief Executive of the Harrogate Hospitals Trust, I can't remember its exact name, but Harrogate Hospital Trust, is also the Chief Executive of the Nightingale Hospital. He tried to rearrange his diary so he could attend this morning, but he was unable to do that. But he has agreed to meet a small group of you. And I know in the discussions before the meeting, Councillor Clark was keen to be involved in those discussions. So again, with your permission, you may want to nominate now perhaps three members to meet with Steve Russell and myself in the next few weeks to pick up this issue outside the meeting and then report back formally to the next meeting of this committee.
Yeah, sure. Well, obviously, Councillor Clark will be one of those. I think Councillor Clark asked if the chair could come, so I'm more than happy to do that. And is anybody else that would be interested in joining us at that meeting? Councillor Smage? Yep, okay. So if we can arrange that, Mike, at some point.
That's fine. Yeah.
All right, brilliant. Lovely. All right, thank you. Now the final item, then work plan and next steps. So that's you again.
Thank you, Chair. We haven't got a programme of dates for future meetings. We had anticipated, and I think in terms of reference that I just referred to, talk about meeting 4 times a year. But I suspect following the discussion on governance earlier on, it may well be that you need to meet relatively soon because of the September deadlines. And what I will suggest, if I may, Councillor Greenwood, is that yourself and Councillor Smage and I set up a discussion with Ian Holmes and his colleagues just to make sure that the dates that they're looking at fit with dates we want, so you can make sure you get scrutiny at the right time and not after the event, so to speak. So that's one item on this. I think the other thing that I do need to mention, that I forgot to mention earlier to Councillor Greenwood, is actually from Bradford. There's been a request to take a West Yorkshire-wide look at access to dentistry and commissioning of dentistry services. And if you're agreeable about that, I'll work particularly with Caroline from Bradford and Councillor Greenwood to put that item together and to put it onto your next agenda. Thank
Everybody
you.
okay with that? I know Councillor Smage, you particularly. Yeah, that's.
Yeah. It affects Kirklees as well, access to dental services. Yeah. So very interested to have that on the agenda. Yeah.
Excellent. Okay. So thank you for all sticking with us. Oh, sorry, Councillor.
Can I, as I tried to raise with NHS England earlier on, workforce issues, the lack of an effective workforce plan and the buy-in from provider organisations to have a responsibility in producing the workforce that we're so desperately short of, it seems to be lacking. A couple of years ago, I was charged with taking forward a subcommittee to try and explore this with the local health economy. Unfortunately, it's proved very, very difficult to get engagement with anyone at a decision-making level to be able to take that work forward. I really would like to see workforce planning at a West Yorkshire level incorporated into the work plan, and using the powers of scrutiny to actually get that to get those decision makers in front of us to try and encourage them to focus on this issue.
No, I agree with that. You mentioned that to Ian, didn't you? And hopefully he's taken that on board. But maybe we should resurrect this committee again. Everybody's up for that.
Or sort of start it off with part of the main committee group, as we've sort of had singular lack of effect at subcommittee level.
Yeah. Okay. Yeah. I'd be up for that, definitely. Yeah. Okay. Brilliant. All right, Alexis, thanks for sticking.